Thanks very much, Alan. And I can tell you it's really a thrill to see my old friends and colleagues and get a chance to introduce them to my new friends and colleagues. And in keeping with what Alan said, coming at the end of the program, my slides start to look like everybody's slides. So I'll try to skip over what we've already been through. So as we've already learned this afternoon, that acute pulmonary embolism is a very common problem. It can be a very deadly problem, accounting for almost 15% or estimated almost 15% of all hospital deaths, because of course many of these patients that we take care of with acute PEs are hospitalized patients with other illnesses or having had other procedures. A very important study was the International Cooperative Pulmonary Embolism Registry. It came out in 1999, and that was a study that was multi-institutional in North America and in Europe. And it looked at, consecutively in the centers that were participating, almost 2,500 patients with pulmonary emboli. And there were a lot of lessons that were learned from which we've been able to figure out more about pulmonary emboli. First of all, we know it's deadly, but not all patients with pulmonary emboli, and most patients with pulmonary emboli don't die suddenly from it. Those who do die over a period of time. And so that, as Dr. Peden pointed out, that's an opportunity to have these patients that may die have those deaths be preventable. We also learned from this that there were some risk factors for patients who were going to die from pulmonary emboli. And there are some things we couldn't really do anything about. Those patients who were old, those who had bad forms of cancer or bad heart disease already. But those patients who were hemodynamically unstable, those patients specifically with a sustained blood pressure below 90 millimeters of mercury, they were more likely to die, a lot more likely to die than those patients whose blood pressure were more stable. And as we learned already today, those patients that had signs of significant right ventricular dysfunction were more likely to die than those who did not. We've talked a little bit about the white paper that came out of the American Heart Association, and from the International Cooperative Study and others, pulmonary emboli have been broken down into several different categories. We learned about massive pulmonary emboli, and those include the patients who are hemodynamically unstable, have a blood pressure below 90 for 15 minutes or more, and those requiring inotropic support. Of course, those who are pulseless, or those who are significantly bradycardic. Those patients who have submassive PEs, they're not hemodynamically unstable, defined by a low blood pressure below 90, but those who have some sign of right ventricular dysfunction, whether it's by imaging or by serologic studies, troponins or BNP or EKG changes. And then those patients who are most patients that are low risk, those patients that don't have any of those findings, and those patients who, with appropriate anticoagulation, are very likely to do very, very well. And if you look at it in a pie graph, most of the patients are low risk, and most of those patients have the lowest risk of having mortality. The massive PE patients, they're the most deadly, that are estimated to have a mortality rate of 58% over 3 months. Fortunately, those are a small percentage of the patients. And then the submassive group, which is somewhere in between, both in incidence and in the likelihood of death. We talked about some of the algorithms of how these patients get treated with regard to anticoagulation, which is most of the patients, and those patients who are recommended to get thrombolytic therapy. But as we learned, thrombolytic therapy is not for free. There is risk, not only with thrombolytic therapy, but also with anticoagulation therapy. And if you look at, this is from the International Cooperative Study, that the risk of major bleeding in those patients who received thrombolysis was greater than 20%. And of that, in this study, in this observation anyway, 3% of them had major intracranial hemorrhage. And in some other reports of thrombolytic therapy, that's as high as 5 or 6%. So again, these are not insignificant problems from the treatment. And as we all know, we don't want our treatment to be worse than the disease. And as Dr. Peden pointed out, there's also patients that have contraindications to thrombolysis, absolute contraindications and relative contraindications. And depending upon how you weigh those risks of contraindications, that can be upwards of 50% of patients that have acute PEs. Well, how about surgery? I mean, no surgery talk would be complete without talking about some of the history and certainly some of the surgeons. Surgeons like to talk about other surgeons. So up in the top right, Trendelenburg, he's a German surgeon in the latter part of the 20th century. Pulmonary embolectomy, it's called the Trendelenburg procedure. It's his idea, although he never really did one. He did a lot, but he never did one. His disciple, right below him, Martin Kirschner, performed the first successful pulmonary embolectomy in 1924. Now, if you think about it, 1924, that's before the heart-lung machine. It was basically, putting somebody on a table, opening their chest, and with a lot of bleeding, trying to rip this clot out of somebody's pulmonary artery. So although there was a great deal of enthusiasm, there was certainly not a great deal of success with early Trendelenburg procedures. The natty-dressed fellow up in the top left is John Gibbon. He was a heart surgeon. He's the father of the heart-lung machine. And interestingly, he was a research fellow at Mass General in the early 1930s. And it was well established that patients who had surgery were quite prone to pulmonary emboli. It was a very common cause of death back in the days when you would operate on somebody and keep them at complete bed rest for 2 weeks or more. And so the role of the fellows and the residents were to sit vigil in patients who were diagnosed with a pulmonary embolism, wait until they died, and then try to do a Trendelenburg procedure. Talk about throwing good money after bad, not a very successful or gratifying endeavor. But while he was sitting vigil over a young woman, he got this idea of a machine, a pump, that could somehow bypass the pulmonary circulation and keep these people alive until you could figure out how to do a more successful Trendelenburg procedure. And down in the bottom left, Dr. Denton Cooley in 1964 was the first person to use the heart-lung machine to do a successful pulmonary embolectomy. But despite that, surgical pulmonary embolectomy has had kind of a bad rap for the treatment of pulmonary embolism. And it's interesting because from a cardiac surgery point of view, it's a pretty straightforward and simple operation. These days, you put somebody on cardiopulmonary bypass, something that we do in this hospital about 10 or 12 times a day. You put them on bypass, you don't need to stop the heart. You make a small incision in the pulmonary artery, and with all due respect to Dr. Lumsden, we just stick a forceps in the pulmonary artery and pull out the clot. And you can make an incision in the main pulmonary artery. You can look into the left pulmonary artery. You can't really see the right pulmonary artery well, but you can also make a little incision in the right pulmonary artery and pull the clot out. Other maneuvers that you can do is under direct vision, pass these Fogarty embolectomy catheters into each of the segments and pull clot out. Another kind of neat thing to do, not very elegant, is to ventilate the patient and gently massage the lungs and use that positive pressure to push the clots out. And you can get pretty impressive results. This is a patient that had a big saddle pulmonary embolism, and needless to say, it's a very large clot that was pulled out. Other patients have fragments of clots, and you should make notice of the fact that many of these clots are casts of big iliofemoral venous vessels, and it is actually quite a very gratifying operation to pull these clots out. Well, so for such a simple operation, why does it have such a bad rap? Well, it has historically had bad outcomes. And is it bad outcomes because it's a bad therapy, or is it a good therapy not instituted or not used on the right people. Well, let's take a look at some of that. So this is a recent meta-analysis that was published just last month in the Annals of Thoracic Surgery, and they looked at close to 1,600 patients who had surgical pulmonary embolectomies, and the in-hospital all-cause mortality was 26%. That's not a great, statistics, but if you look at the meta-analysis, it goes all the way back to 1965. It's a real assortment of volumes and outcomes, and as you go from oldest to newest, this line being mortality, the outcomes start to get better. The volume of patients in this series is really mixed, and that I think it's really not a very good analysis to look at patients over the last 50 years with this therapy. The group at Johns Hopkins a few years ago looked at a nationwide survey, a nationwide inpatient sample survey, and they looked at 2,700 patients that had pulmonary embolectomy. And again, the mortality rate, not a very laudable 27%. And they looked at, in this survey, both teaching hospitals, not teaching hospitals, big hospitals, small hospitals, and interestingly, whether you're a big hospital or small hospital, teaching hospital or not a teaching hospital, the outcomes were the same. But if you dig down a little deeper, none of these hospitals really did a lot of this. The number of procedures that were done in these hospitals were 1 or 2 a year per hospital, in less than 1 a year, or less than 1 every 2 years per surgeon. And it's not just the surgeon. These are infrequent operations done on very sick patients that require very effective and efficient teamwork. And with this frequency, it shouldn't come as any big surprise that the outcomes weren't as good as you wanted. There have been some institutions that have really taken an interest and taken a lead on using surgical pulmonary embolectomy for the treatment of these patients. And as Dr. Peden alluded to, dead is dead most of the time. But if you take dead people to the operating room, you're oftentimes likely to end up with a dead patient after the operation. So it's all in the patient selection. So this group from California, they reported they had 11 patients, and they had a 25% mortality. And if you look at those patients who died, the 3 patients who died, all 3 of them went to the operating room after cardiac arrest with CPR in progress. And so yes, dead is dead. But they did have a couple of patients who were getting CPR that lived. And that the good outcomes were patients who went to the operating room not getting CPR. Interestingly, if you look at whether or not in this group of 11 patients, whether or not they got thrombolytics, half of them didn't because of contraindications. Again, pointing out the fact that even in these very sick, massive and submassive patients, that their ability to get thrombolytics is not always an option. And as they did a review of the literature, looking at a number of the papers that were reported in that meta-analysis, they looked at those patients that went to the operating room getting CPR. Not surprisingly, there was a greater than 50% mortality in that series, those series of reported studies. And in those patients not getting CPR, that actually mortality was about 12%. And so again, selection, doing the right operation on the right patient is important. A real leader in the surgical field anyway, of the surgical management of pulmonary emboli, has been the Brigham and Women's Hospital up in Boston. And it's interesting that one of the champions of the surgical pulmonary embolectomy is Sam Goldhaber. And the Brigham has done a terrific job, and we'll see a few of the series that they have published on pulmonary embolectomy over the years. And in 47 patients that they reported in 2005, their outcome, they had a 6% mortality rate. in patients that had massive or submassive PEs. And if you look at the patients that they selected, about 45% of the patients had contraindications to thrombolysis. About 10% of those patients had received thrombolysis or received catheter-directed therapies that were unsuccessful. And then there were a number of patients who had either clot in transit or patients who had significant right ventricular dysfunction. That made up about a third of their patients. John Byrne, who was one of the senior surgeons at the Brigham, had gone down to Vanderbilt. They looked at their patient series, and again, not all pulmonary embolism patients are the same, and they looked at the clot burden in their patients with massive PEs, and they stratified them as to whether there was centrally located clots, those were type A, or those who had more peripherally located clots, those were type B. And again, these aren't randomized patients, these are different patients, but if you look at those patients who had type A clot burden and compared them with those that were treated with medical therapy, again, not randomized, that the outcomes of those patients treated with surgical embolectomy was better than those treated with medicines. And then a pretty impressive series back at the Brigham a couple of years ago, that those about half were massive PEs, half were submassive PEs, and again the breakdown as to why they received it relative to not being able to get thrombolytic therapy. They actually had a pretty impressive outcome. The overall mortality in this 115 patient group, the total mortality was 7%. And in the submassive group, it was below 4%. And so what we're going to be talking about more tomorrow is the impact of the subset of patients who have had PEs that go on to develop pulmonary hypertension as a consequence. Who and why those patients occur is still a work in progress, but I think that it is important that for one way or the other to make it so that these patients don't have residual thrombus or certainly have residual pulmonary hypertension. This group from down at Emory, their series again of 44 patients, very impressive surgical outcomes. There were no deaths in those patients with massive PEs. There were 9 patients. And they had 1 patient out of 35 who died with surgical pulmonary embolectomy in the submassive group. And interestingly, if you look at in follow-up 30 to 60 days later and look at their right ventricular function, the degree of tricuspid regurgitation, and their estimated pulmonary artery systolic pressure, there was a significant difference and improvement. Whether or not that translates into less pulmonary hypertension remains to be seen, but at least this is a reassuring trend. So Dr. Chanik had mentioned, and a few others, about ECMO. Again, not another procedure that has glorious outcomes to report, because again, it's a procedure that's frequently performed emergently on patients who are getting CPR. There are 2 different types of ECMO circuits that we can bring to the bedside in patients. VA ECMO, that actually is a type of heart-lung machine that will support the circulation, as well as provide oxygenation and ventilation. And then there's VV ECMO that is good for gas exchange. There has been really an ECMO explosion, if you will, within the last decade in supporting patients for any number of reasons, including pulmonary emboli. And before I left Boston, among our series of ECMO patients, the subset of patients receiving ECMO for hemodynamically unstable pulmonary emboli those are the patients with the best survival. A great thing about ECMO now is the circuits and the systems that we have are very compact. They come in well packaged, and you can bring them to the ICU, you can bring them to the emergency room, and you can get somebody cannulated and on ECMO very quickly. It can be done percutaneously, usually in the groin, and you can take somebody who's very hemodynamically unstable and stabilize them. And in some cases, that is enough therapy for patients with massive PEs that will resolve, or you can resuscitate them on ECMO and then take them either for surgical pulmonary embolectomy or take them to the cath lab for any other catheter-directed therapy. This is a recently reported series out of Westchester, New York, and the group up there, they had 29 patients with either massive or submassive PEs. 4 of those patients were determined in the emergency room to be too hemodynamically unstable to go for pulmonary embolectomy and were placed on ECMO support in the emergency room. Their 30-day mortality of these patients, 0. All of these patients got better and were discharged from the hospital. The ECMO, so 3 of the 4 ECMO patients didn't need any other kind of therapy for their pulmonary embolism. One of the patients had a persistent filling defect, had a previous history of a leiomyosarcoma, and went to the operating room and had not only clot, but some recurrent leiomyosarcoma extracted from the pulmonary artery. Dr. Peden and Dr. Lumsden talked a lot about some of the other catheter-directed therapies. This is a picture of Dr. Greenfield's embolism suction device. He started working on this back in the 70s, and it's an interesting device. It's a small catheter with a suction tip at the end, and it's directed into the pulmonary. You can steer it into the pulmonary artery. I've never used one. I'm told it takes a fair amount of skill to do that. And then to get the clot out, you get the clot and you have to pull the clot out from the vein, and the clot can fall off. It's a great idea that never really got much traction. Dr. Lumsden talked about the angiovac or the vortex. Can get a fair amount of clot out from that, and it essentially is a bit of a bypass circuit. You suck all the blood out, including the clot, and then have what blood comes out the other end infused rapidly back into the patient. The challenge with that, as was mentioned by Dr. Lumsden, is it's very difficult to steer beyond the beginning of the main pulmonary artery, and certainly very difficult to get into the branch pulmonary arteries. So I think that I'm not suggesting that surgical pulmonary embolectomy be performed on everybody with pulmonary emboli. I would recommend, on the contrary, that it be used very judiciously on patients with pulmonary emboli, but I do think there still is a place for it. These are the recommendations for some kind of mechanical embolectomy from that white paper from the American Heart Association. And at least the recommendations there are for patients with massive PEs who either there's a contraindication for thrombolysis or have received thrombolysis and have failed, or patients who have submassive pulmonary emboli with severe right ventricular dysfunction. These were some guidelines that were added, not guidelines, but practice patterns from the Brigham, and to that, patients who, in addition to the patients who are contraindicated for fibrinolytic therapy, those who have clot in transit, those who have a big patent foramen ovale. There are patients that have had large paradoxical emboli that have gone across PFOs, and I do think it is a good therapy for those patients who have significant right ventricular dysfunction. So pulmonary emboli continues to be a deadly disease. I do think that it is important to not only make the diagnosis, but to put these patients into the right category and try to treat them in the best possible way, and follow through to make sure that these patients have recovery after your therapy. And that in selected patients, I do think there is a role for surgical therapy that includes not only surgical pulmonary embolectomy, but also ECMO. I do think that the use of ECMO in unstable patients, certainly one of the most, what was being done in Boston at the time I left, is those patients who got thrombolytic therapy that failed, rather than take them right to the operating room and do heart surgery on them, those patients bleed a lot, and you can't stop that bleeding. But if you put them on ECMO and allow the thrombolytics to metabolize, then you can take them to surgery if they need to thereafter. And with that, I will stop. Thanks very much.